Welcome to EHJ Today at the annual meeting of the European Society of Cardiology 2014. I'm Filippo Crei, Associate Editor of the European Heart Journal, and I'm sitting with Professor Cappato from Milan and Professor Bodi from Freiburg. Professor Cappato is the PI of a very interesting trial, the X-VERT Trial, of rivaroxaban versus warfarin in patients undergoing elective cardioversion. Can you tell us more about the background of this trial?
Yes. Cardioversion is a very popular technique used worldwide, and usually the current standards of therapy are vitamin K antagonists to protect patients for the inherent perioperative thromboembolic risk. The recent introduction of novel oral anticoagulants has offered clinicians a unique opportunity to test these new drugs also in the setting of acute cardioversion or specific of elective cardioversion. And this is the design of X-VERT, to evaluate the efficacy and safety of rivaroxaban 20 milligrams once daily versus VKA in patients undergoing elective cardioversion of nonvalvular atrial fibrillation. The study included 1,500 patients with a 2-to-1 randomization ratio. Both early and delayed cardioversion were contemplated in the study, and the decision was taken according to the common clinical practice. After randomization, patients underwent cardioversion within 1 to 5 days in the early group, within 21 to 56 days in the delayed group. And they were then followed for 42 more days until end of study. The two patient populations were well balanced in terms of clinical characteristics and demographics. The primary endpoint was in a composite in terms of efficacy, a composite of stroke, transient ischemic attack, myocardial infarction, and a cardiovascular death and peripheral embolism. The primary safety endpoint was major bleeding. During the entire study duration, in terms of primary endpoint, we come to the results.
Okay, please, can you summarize that?
10 patients overall experienced at least one primary efficacy outcome event. Of them, 5 out of 978 in the rivaroxaban arm, accounting for a 0.51% incidence, and 5 out of 499 in the VKA group, accounting for 1.02%. The risk ratio was 0.50 in favor of rivaroxaban, but the confidence interval was overwhelming the identity line, and the reason is that the study was exploratory in nature. The reason why this was not a comprehensive non-inferiority trial is that because of the low incidence, expected incidence of events in the control arm, the VKA arm, the total number of patients that would have been required to provide such a study was deemed to be too high, in the range between 25,000.
Can you tell briefly about safety endpoints?
Safety, 10 patients again had at least one safety event, 6 of them in the rivaroxaban arm, accounting for 0.72%, and 4 in the VKA arm, accounting for about 1%. Again, a risk ratio slightly in favor of rivaroxaban, but with a 95% upper bound overwhelming the identity line. So in summary, we can say that the study provided evidence on an exploratory nature that rivaroxaban was associated with a low incidence of primary efficacy and safety events, and similar to the incidence observed in patients receiving vitamin K antagonists.
Professor Bode, what are we learning from this trial, in your opinion?
Well, let me tell you, I think within the limitations that Dr. Cappato has mentioned, which is the size of the trial, but within what is feasible today, I think this is to be a landmark trial. And you are to be congratulated for having led this trial with your team. This is the first time we are getting randomized prospective information. So far, only retrospective information from the large seminal trials in AF have been available. And therefore, this is something that's very new. I think with the limitation that here is that the sample size is not adequate for a non-inferiority trial, we can say that we can gain confidence, as you worded it also in the publication, that we have confidence now that we have a safe and effective alternative for vitamin K antagonists for the cardioversion procedure. Having said that, let me add one thing. I think it's, if we look at it closely at the trial, it's a strategy trial. Because those that had early cardioversion and late cardioversion were treated a little differently, and that was not randomized for. So it's early cardioversion with a transesophageal echo, or late cardioversion with a longer time of anticoagulation but without transesophageal echo. So basically only the randomization was only for the drug, but not for the TEE, and therefore it's short with TEE against longer time without TEE. That needs to be also taken into account when we look at the results.
What about the implications for current practice? Do you think can we safely shift from warfarin to rivaroxaban?
Well, we have to consider that about 1,500 patients were part of this study. Of them, 1,000 were treated with rivaroxaban, and the incidence of events observed was low and comparable with the one observed with vitamin K antagonists. So, under the limitations that we have all discussed before, we can say that these results offer a reassuring profile in terms of safety and efficacy for all those patients who are candidated to elective cardioversion, to restoration of sinus rhythm in nonvalvular atrial fibrillation. One additional finding is that given the pharmacokinetic profile of the drug, it was much easier in the study to prove that if you receive rivaroxaban, your delayed cardioversion strategy can be planned well in advance in the vast majority of patients, which is hardly the case for vitamin K antagonist treatment, as we all know from daily practice.
Putting together the current evidence, do you think that this is a class effect?
I think we don't have elements enough to mention this. If we extrapolate the information that we have collected in larger trials, in which 4 different novel oral anticoagulants have been individually tested against the same comparator, showing a similar class-like effect, we may consider that most of the data that we have collected in X-VERT may be applied also to all other drugs. However, I think one should be cautious to translate this information into an immediate clinical applicability of other drugs that have not been tested. On the other hand, if you are on apixaban, dabigatran, or edoxaban, the remaining 3 novel oral anticoagulants, in addition to rivaroxaban, and you are already on this drug treatment and you require electrical cardioversion, sub-analysis from the former large trials have provided similarly reassuring evidence that you would not require to be discontinued or shifted to vitamin K antagonists before cardioversion. But that is in a chronic setting.
Makes a lot of sense. We have time for a very short take-home message.
I think the take-home message is if you have nonvalvular atrial fibrillation, which is symptomatic and requires restoration of sinus rhythm, you can, based on the data of the study, safely and effectively consider the possibility of using rivaroxaban 20 milligrams once daily has a perioperative protection against the inherent risk of thromboembolic events during the phases preceding and following cardioversion.
Very well. I wish to thank Professor Cappato and Professor Bode for this interesting conversation at EHJ today.